right, thank you very much. Thank you, Sages, for the opportunity and accepting this for a podium presentation. I have nothing to disclose. And what I'm going to try to share today is our data comparing both POEM and Heller, focusing on the extension on the gastric side of the myotomy. POEM is, being rapidly adopted. Every center that started POEM has grown a lot in the number of achalasia patients, but reflux remains to be a concern. Postoperative GERD remains to be a concern. And all of those that have done POEM have noticed that going those 3-4 centimeters on the gastric side that we've learned in Heller's myotomy doesn't seem to be quite necessary because we have a different control on when we are done with the myotomy. So the first comparison was probably this white paper that started showing that Heller and POEM were having similar results, but with less morbidity, with less pain, earlier discharge. And when we started seeing the reflux, this is similar data from the group in Portland, when they show that this is one of the few papers that actually shows pH control in both groups, and we've seen similar results. Not that POEM doesn't have GERD, but Heller also has a considerable GERD rate, and so our focus is, can we control that somehow? And we have some other papers that show that reflux is a real problem in POEM with up to 55% esophagitis. This is by a paper by Noe, with the founder of the technique. So should we be doing the same? Should we go and do 3-4 centimeters on the gastric side? Why do we do that on the Hellers to begin with? And we've learned that by different groups, mainly the group in Seattle by Pellegrini, where they've shown that if we did a shorter myotomy on the gastric side, we would have a higher recurrence rate. And somehow, worldwide, that was adopted as a standard of care. But when we do a Heller myotomy, we are not controlling when the LES opens. And that's something that when we started doing POEM, we realized that could change. And the first answer to that was this paper by Pandolfina showing with this distensibility study that after 2 centimeters of myotomy on the gastric side, there was not a greater change in distensibility. So we decided to analyze our own data, and we analyzed our first 35 POEM cases with our last 35 Heller door cases, combining always with a door fundoplication. There's a difference a natural difference in follow-up, but we measured effectiveness with Eckhart score, the clinical symptoms, the HQRL for reflux, and we did EGD at 6 months in all the patients and the need for PPIs. So what we did is, on the POEM patients, instead of setting a length of the myotomy on the gastric side, we if you can play the video, please. We set a heel type 2 as a satisfying way of completing the myotomy. So we use a spontaneous LES opening, a smooth passage of the endoscope, which normally we see after the myotomy. And when you do the retroflexion, having a heel type 2, knowing that you went with the tunnel. And if that happens, we are satisfied with that. And we measured how long we did the myotomy, and it never exceeded those 2 centimeters. And in the Hellers, we did the standard of care of 3 centimeters. So we compare, and those are the results. You can see the Eckhart score decreases significantly in both groups. There's a significant drop. That P is for the drop, not the comparison. The hospital stay, there is that P is comparing both, so there's a significant difference in the average days of stay, which is consistent with the literature. There were no difference in major postoperative complications, and there was no difference in the need of reintervention. So when we look at the reflux symptoms, we had a very similar rate, 20% for POEM, 17% for Heller. the need for PPI. We have a very low threshold for PPI indication, so minimal symptoms on reflux. We put the patients under PPI. Our experience is that they do okay on PPI as published in the literature. So so far, none of the patients that we did POEM were converted to a fundoplication. And esophagitis, we found about the same rate. So it's not that the patients don't have reflux, but it's comparable to what we see in inhalers. Is this optimal? Probably not. But I think that controlling the length of the myotomy can explain some of the difference in the different GERD rates that we are seeing in different publications. So we focused on that, and those were our the conclusions. So we believe the POEM is safe and effective. I apologize for the Spanish on the head letter there. We have a comparable post-operative GERD, compare effectiveness with reduced morbidity, and we do think that the length of myotomy using the extensibility measurement can play an important role, and we definitely warrant further studies for that. With all that said, I think that teamwork is the most important, so I'd like to acknowledge my group. This is not the group of only one person, and with that, I would be happy to take any questions. Thank you.
Any questions from the audience? That's a great presentation and a nice paper. I was interested about how you commented on that you were doing endoscopic dilatation for somewhere between 20 and 30% in both your groups. So people had recurrent achalasia, and so you had people that had their POEM, and then if they had recurrence, then they had pneumatic dilatation. Is that your kind of go-to therapy? Or?
Yeah, the reintervention is usually mild. So we have a different threshold for doing a post-op dilation. Normally it's an Eckert score greater than 3. That is what published. We have a very low threshold. If the patient is not able to fully pass solid diet like meat, we would do a little crack and open it. So that probably explains why we have a high rate of 20%, even inhalers. We are very aggressive in having a normal a patient with no dysphagia at all. But those are the real numbers that patients that come back. The patients after Heller, they come back. They may take longer than the POEM, but they come back.
No, it's fascinating because certainly there's been arguments for performing POEM if somebody's had a previous Heller, and one of the but then so if you had a POEM, but then you have a recurrence, so so the argument is not to do a repeat POEM, a repeat myotomy, but rather you would go to endoscopic dilatation as part of your algorithm. And is that a pneumatic dilatation with the and what you typically would start off with a 3 centimeter dilatation in that setting? Or?
Yep, and actually our finding is that it's not the same a balloon dilation for a primary ejaculation, like a primary treatment, than when you go with a balloon after a POEM. It's just, you just need to touch it and it opens back. So it's a little bit of fibrosis probably that creates there. So to me, it's a complete different dilation. So one thing is when you dilate a primary echalacia with no treatment and you're trying to do just pneumatic dilation. Another thing is when you go post-op after a POEM and you just touch it to, crack the little fibrosis that formed there. And usually it's one dilation and the patients don't come back.
So you would use the same approach today for if somebody comes in, because this is a past experience versus a more current experience, but if somebody has dysphagia post laparoscopic Heller myotomy, so your first line therapy in that patient would be
a pneumatic dilation.
Pneumatic dilation, okay.
Yes, and if it is recurrent, then we do a POEM on the posterior side. But always the first attempt after post-op is a mild dilation with the balloon. If we see an Eckert score above 3 and a real recurrence, then we do a POEM on the posterior side. We have 6 patients that we've done that were Hellers first.
Nice.
So one last follow-up question, actually. So the premise of using compliance as the metric for achieving adequate myotomy with tools like the EndoFlip has been debated back and forth. And it seems to me that what you're arguing here is that using that tool would potentially change how long you would do your myotomy in a Heller as well, because then you might not use a 3 centimeter long myotomy, but use the same endpoint of increase in compliance. And do you think that would actually decrease the reflux rates even further?
Absolutely. I think the only reason why we do 3 centimeters in the Heller is because we don't know. And that was before the surgeons had the endoscope in their hands. You know, now probably if you do a Heller and you do an intra-op endoscopy, you don't need to do 3 centimeters. I think that was a set number to make sure you cut it all, but that might change.
Thank you.
Mm-hmm.